Good day, everyone. Welcome to our course NUR 251, Reproductive and Sexual Health Nursing. So today I'm going to present to you the topic on obstructed labor and also prolonged labor. Now let's have a look on the first topic, that is obstructed labor. Okay, now let's have a look on the definition of obstructed labor. It is a condition in which the fetus fails to descend through the birth canal due to the congestion despite strong uterine contractions. It usually occurs in the pelvic brim or in the outlet as in deep transverse arrest on the android pelvis. So the suitable pelvis for normal delivery is gynecoid pelvis. Yes, circumstances occur as a result of poorly managed or neglected birth management. Okay, this is the definition of obstructed labor. The incident of obstructed labor happened because of three conditions. That is, number one, cephalopelvic disproportion. There is no compatibility between mothers and fetus, usually related to the size of the fetus, larger than the mother's pelvic space or the mother's pelvic possibly contracted. Number two, deep transverse arrest. Consequences of the occipital posterior position of the fetal head. Number three, malpresentation. The fetus is in the brow or shoulder presentation or is always in the mental posterior position. Obstructed labor happen because of this incident. Number four, pelvic mass. The presence of fibroids located in the lower segment or in the cervix that prevents the fetal head from descent and in turn cause obstruction. Number five, ovarian tumors or bony pelvic tumors prevent the fetal head from entering the pelvic. Okay, obstruct the descent of the fetal head. Number six, fetal abnormalities. Abnormality of fetus such as hydrocephalus, conjoined twins, log twins, also cause of cephalopelvic disproportions. Early signs of obstructed labor. Number one, the presentation part does not enter the pelvic rim despite good uterine contractions. After making sure the mother does not experience distended bladder, full rectum, and excess liquor. Number two, the presentation part fails to descend, causing the dilatation of the cervix to be slow and the cervix to be likened to hanging. Number three, uterine contractions cause pressure on the membranes that are above the cervix and in turn cause the membranes to rupture earlier. After we've gone through the early sign of obstructed labor, now let's have a look on the late sign of obstructed labor. Number one, mother looks dehydrated, ketotic, and suffers from constant pain. Number two, mother has a fever and tachycardia. Number three, lower segment tenderness and difficult to perform abdominal palpation due to pain and maternal distress. Number four, the presentation part is difficult to feel during vaginal examination due to the molding condition and the succedaneum caput due to uterine contractile pressure. Number five, low urinary output and the possibility of hematuria. Number six, fetal distress is detected from the mother's condition showing tachycardia while the fetus is experiencing bradycardia. Uterine contraction persists and fail to rest between contraction result in a tonic contraction condition, that is hyperstimulation. Okay, the lower segment becomes thinner and the longer while the upper segment becomes shorter and thicker. This diagram shows the features of the cervix in normal labor and obstructed labor. Late sign of obstructed labor, number 9, retraction ring or bender ring looks like a full bladder, and during catheterization, only a small amount of urine is obtained. Okay? As you see in the diagram. Number 10, the uterus becomes tired and stop for a while, then follow again by a strong and frequent contraction. During vaginal examination, the vagina feels hot and dry, while the presentation part cannot be moved. Okay, there's no progress of labor. Management of obstructed labor. As a nurse, we have to do the assessment at the relevant antenatal level. A. History of obstructed labor or difficulty giving birth in the past. B. Abdominal examination related to malpresentation or cephalopelvic disproportion sign. C. Refer immediately before the mother starts working so. Immediate action can be taken to prevent the occurrence of obstructed labor, such as perform abdominal palpation and vaginal examination for determine the portion of the presentation in the pelvis. Number 2, monitor contraction related to length, strength, and frequency using pantograph to detect abnormal progress. Number 2, the management of obstructed labor, intravenous infusion to balance the body's electrolytes or avoid dehydration. Number 3, group and cross-matching, blood in preparation for transfusion if necessary. Number 4, monitor the mother's vital sign and fetal progress and inform the mother, husband, and doctors from time to time. Number 5, if obstructed labor is detected during the first stage, the choice of birth method is lower segment cesarean section if rotational and instrumental delivery does not allow. Number 6, if in a community area, take the mother immediately to the nearest hospital and tell the situation clearly so that equipment is provided so that the mother and fetus can undergo the birth process safely, where there is a pediatrician to perform monitoring and resuscitation if necessary, because the fetus is likely to develop asphyxia. There is an obstetrician as the mother may have complications such as ruptured uterus and repair as well as hysterectomy may be required. Let's have a look on the complication of obstructed labor to mother, that is maternal. Bladder trauma is due to the fetal head pressure as a result injuries during the labor process. Vesicovaginal fistula because of prolonged pressure on the bladder wall and vaginal wall resulting in necrosis and urinary incontinence. Number 3, intrauterine infection due to prolonged ruptured membrane. Number 4, rupture of uterus as a result of tightening of the lower segment of the uterus, prolonged contraction. Number 5, hemorrhage is due to rupture of uterus or severe tear. This is the complication of obstructed labor to fetus. Number 1, intrauterine asphyxia, lack of oxygen supply to the fetus. Fresh stillbirth is due to intrauterine asphyxia. Number 3, permanent brain damage is due to obstruction and intrauterine asphyxia. Number 4, neonatal pneumonia is due to ascending infection or meconium aspiration. This is the psychology impact of the obstructed labor or prolonged labor. The incident carries the psychological effect of trauma to the mother due to the experience of pain and difficulty giving birth. The possibility of anxiety and fear increases where there will be a similar problem in the future content or birth. A clear explanation of the situation should be given to the mother and husband are confident to plan the next birth. During antenatal visit in the next pregnancy, doctors and nurses should listen to the complaints related to anxiety. Then steps will be taken to reduce pain and anxiety by explaining the use of adequate analgesic or epidural anesthesia during labor. That's all about the topic of obstructed labor and also prolonged labor. Thank you very much.